Good morning. Computer assisted surgeries are no longer a dream from the distant future. They're slowly becoming a part of routine surgeries, with navigation guidance receiving much attention. That brings us to this systematic review, which hopes to answer two questions. Do navigation guided surgeries really provide a promising solution to the challenges faced in the management of tumors involving the cranio-maxillofacial region, and what is the contribution by various countries in this regard? Before we set out answering that, let's look at the basics of surgical navigation systems. They're analogous to global positioning systems, that is the GPS, where a map is comparable to patient scans, tracking to positioning of the surgical tools, and finally coming up with the optimal route to trajectory of surgical tools to target. So the typical navigation workflow involves taking preoperative scans like CT and MRI with registration markers and additionally making a virtual surgical plan. In the operating room, invasive or non-invasive registration marker methods can be used to orient the preoperative images to actual patient coordinates. And once image to patient registration is complete, real-time three-dimensional positioning of the instruments can be obtained. So coming to the challenges faced in the management of tumors using conventional surgical techniques, they can be summed up in 3 points. One is the high rate of positive resection margins following tumor removal and the poor localization of the tumor bed. Two is the inadvertent injuries caused to vital structures, especially when performing surgeries involving the deep regions of head and neck. And third is the difficulty in obtaining optimal cosmetic contour and symmetry even after virtual surgical planning was introduced. It was found that a tool to transfer the plan intraoperatively was needed to optimize the post-surgical outcomes. To find conclusive evidence that answers the questions put forth, a systematic search of the PubMed database and a citation search of the included articles were carried out using the mesh terms described, and this generated a total of 2,121 articles, and after factoring in the inclusion criteria, 28 articles were selected for this review. 3 areas of interest were identified, the first of which were biopsy procedures. Of the 3 studies that were included, 2 focused on the use of fluorodeoxyglucose PET scans to effectively delineate tumors. The general consensus was that navigation-guided biopsies are minimally invasive and that they had a diagnostic accuracy of about 90%. The reasons for misdiagnosis were stated as insufficient biopsy sampling due to incorrect trajectory of the needle. Limitations included inconsistencies in sampling superficial or flexible lesions due to image drift and the misdiagnosis of cystic lesions. Second area of interest was the surgical management of tumors. Of the 13 studies included, 6 studies evaluated if or not navigation-guided resection of tumors reduced the incidence of positive margins. A statistically significant decrease in the positive margins was reported, with a concurrent decrease in locoregional recurrence rate. Bitterman et al. Conducted a prospective study that compares virtual and titanium clip markings of tumor resection margins. It was found that there was a better localization of tumor beds in the maxillary region, and this in turn could help reduce radiation dose to that region. 4 studies evaluated the accuracy of surgical contouring, and a study by Bao et al. Found that there was a statistically significant decrease in asymmetry index values of the test group when compared to control group owing to real-time visual feedback. A study by Hassan et al. Used intraoperative CBCT imaging rather than preoperative images to guide osteotomy cuts. They found that the mean cutting accuracy was less than 2 mm in comparison to the osteotomy cut planned on pre-resection CBCT. One of the major limitations reported include image drift, that is, the topographical changes that occur intraoperatively due to soft tissue manipulation during surgery. This reduces the accuracy of navigation and could potentially be overcome by real-time intraoperative imaging. The final area of interest was reconstruction and rehabilitation post-surgery. Of the 12 studies included, around 67% of the articles focused on the reconstruction of mandibular defects. Post-surgical outcomes were compared to both the control group and the unaffected side in the same patient in terms of chin deflection, condylar deviation, etc. An overall improvement in both functional and aesthetic aspects was reported. An innovative strategy for fabrication of fibula flap was reported by Li P et al., which was said to decrease the incidence of vascular crisis of the fibula flap. Studies focusing on maxillary and orbital defects, Reconstruction, reported that virtual surgical planning using the mirroring tool for unilateral defects resulted in better reproduction of midface contour and reduced the incidence of orbital complications. The major limitations reported included the use of surgical navigation systems in mandible due to its mobile nature and the associated learning curve of having to simultaneously follow the path of the instruments on a screen. In the country-wise distribution of studies, it was found that the majority of studies were conducted in China, suggesting the high acceptance rate of this technology for the management of cranio-maxillofacial tumors in this country. Before concluding, I'd like to discuss a few takeaways from this review. The level of evidence that was obtained to answer this research question was unsatisfactory due to the lack of randomized controlled trials and the retrospective nature of most of the studies. Despite the study limitations, one common opinion expressed in all the studies was that surgical navigation is an ideal virtual reality bridge. And this statement was further supported by the narrow error of margin between postoperative effect and the virtual surgical plan. For the use of navigation systems on mandible, majority of the studies either use dental splints or maxillomandibular fixation to immobilize the mandible. A study by Hassan et al. Developed and used a custom reference tracker for mandible that does not require the mandible to be immobilized. This resulted in reduced navigation error and coming to the complications that were reported in the test group when compared to the control group. Fewer were reported in the test group, but this was found to be statistically insignificant. Coming to the operative time, majority of the studies reported an increase in both the preoperative planning time and the operation time. But one important point to be noted is that the time to actually carry out the surgery after the registration process is complete is decreased due to the preoperative planning. And issues reported when using the navigation system included a systematic error of registration, which is found to be negligible, and the dislocation of reference frame and few of the challenges as stated before. The search for surgical navigation systems related research in India resulted only in a handful of articles, but none of them qualified for inclusion. This underlines the need to experiment with this technology in India. To conclude, the pros of using navigation guidance in the management of tumors involving the cranio-maxillofacial region do outweigh the cons, at least in cases of advanced tumors and tumors involving the deep regions of head and neck. The need of the hour is to conduct prospective studies and randomized controlled trials to unearth the full potential of navigation systems. Further research can be directed towards improving the accuracy and simplifying the whole process of using navigation systems. Studies demonstrating innovative techniques like intraoperative imaging and the use of dynamic reference frames do look promising. And these are my references. Thank you.